Okay, let's talk about dressings. So again, all of this starts with pre-planning. We want to make sure we turn our catheter away because that makes placing a dressing a lot easier. And the flatter we can plan out for our area around our insertion site to be, the better the dressing is going to stick, the less maintenance the nurses will have to perform, and the less infections we'll have. So when we're talking about the Tegaderm CHG securement dressing, it has the CHG in that pad. We want that pad over our insertion site. The hub of the central line we want to be under the dressing. And then when we seal the dressing all the way around, we don't want there to be any air gaps. This is another reason, one more time, why we want a flat area for the dressing to be as much as possible. Curves and bends make the dressing not want to stick. And then the last thing is we want minimal blood contamination. What does that mean? That means that when you're done with your central line, before you place the dressing on, you need to use another CHG and clean off any excess blood, and there needs to not be any active bleeding when you put the dressing on. If there's active bleeding, you need to stop the bleeding before you put the dressing on, because as soon as you turn that dressing over, if there's blood under the dressing, the nurse is going to immediately have to change it, which then hurts all the things we've done to maintain a nice aseptic technique. The last thing is we want to use our line caps. We always use needleless hubs. That prevents needle stick injuries. They're also sealed and don't use a needle, so this also prevents infections. And we want to use chlorhexidine caps, or called Kuros caps, on the top of this needleless hub. This helps maintain a maximum sterile barrier from the hub all the way through insertion. All right, the first thing starts with preparation. We want to select the right place. We want to make sure that our vessel is appropriate, it's big enough to handle our catheter and meet our needs, and then we can pick our necessary catheter length. If we need to shave, we go on and shave. We consent the patient, we get everything ready, we get our central line, which has all of our bundle kit in it already, we get our gloves, our transducer comfort, we get our nurse, we're in the room. Once we've inserted the central line, we want to make sure that we have thought about where we're putting the insertion site so that we can maintain it, as well as turning the catheter away from the drool, and so to make it easier to maintain. We re-clean the insertion site with extra CHG to remove any blood before we put the dressing on. And once we put the dressing on, we make sure that it's centered, the insertion site centered under the CHG, and the hub is under the dressing. We initial, date and time the dressing. We place our hubs on the catheters and our Kuros caps. We get an x-ray. We make sure that it is appropriate. We tell the nurse through an order that they can use it, and we document all this in our chart. This is what a triple lumen that is placed appropriately looks like. This is a Quartus, looks exactly the same. Again, everything underneath the dressing, it's all appropriate. And here is a pick. Again, same thing, all the same. So let's play a little game here. What's wrong here? Well, here we have a central line. This is a pick line, but the problem here is that it's bleeding. Once we get blood under our CHG, it's not as effective, so this dressing has to be changed. What that means for you as a central line inserter is that if you have active bleeding when you go to put the dressing on, you will immediately have to replace it. So stop the bleeding, whatever that means. Oh, but the patient is coagulopathic. Well, maybe you shouldn't be putting a central line in them. Here's the same kind of situation. We have blood underneath the dressing, but notice that this is a location that is extremely difficult for the nurse to take care of. We actually have good placement of the dressing. There's very little air gaps, but imagine trying to replace this with those folds of tissue. Maybe we could have gone to another site that would have been easier for the nurse to maintain. Think about your patients. Here is a dressing that the resident, I'm sure, was called and said they're bleeding, they continue to bleed, so they put a compression dressing on it. That's not going to work. You need to stop the bleeding before you put the dressing on, not try and stop it after. What about this one? Well, the hub is not underneath the dressing. That's not going to work. Also, the dressing is up into the beard. We didn't shave the beard. We have to think about what we're doing and be patient-specific when we're talking about central lines. What about this? This patient comes back from dialysis and this is what you see. Well, first off, it's the wrong dressing. You need to ask the nurse to change that. Second off, they're missing the caps to their central line. So remember, we should have the needleless hub and a Kuros cap. If we don't have either one of those, even though this is not our central line, it's our patient, we have to let the nurse know so that this can be appropriately addressed and taken care of so our patients have the best care possible. What about this central line? Well, a few things to note here. Number one is that it's not turned away. The other thing to note is there's traction on the central line. The lines themselves are trying to pull the central line out. Yes, but you sewed it in. That is correct. But that traction on the dressing makes it come apart. And you can see that that's happened because somebody's put tape on both sides to help the dressing adhere. That's not going to work. Also, you can note that it's in the beard line. So how about turn this line down, and then we have a little bit of slack so that when the lines get pulled a little bit, the traction is not to pull the line out, but to pull the line down. It makes much more sense, and the dressing will stay much better. Here's another one. So we've got the dressing in the hair because we took it straight up, and the dressing on the ear. Not appropriate. This looks really good, except where's the CHG component of the dressing? Well, the patient is CHG allergic, so they wrote that on the dressing. So you can't avoid this, right? You're going to get an infection because we have very little infection control. No, this is a post-op patient. We know we're going to take the central line out as quick as possible. So remember, when you're planning for a central line, plan for the removal. If in this patient you know that you can't keep the central line in very long, the number one goal here is to get this line out as quick as possible. What about this one? Well, again, if you're using a hub, you did something wrong. It was either the wrong size catheter or you unnecessarily use it. We want to minimize our use of anything that damages the skin. How about this one? Well, again, this is a patient that came back from dialysis. The hub is not covered. It has a lot of biofilm on it. We need to make sure we're taking care of these dressings every day. So if you see something wrong with the dressing, if you see something wrong with the line, tell your team. Let your nurses know. Here's one where the hubless cap has fallen off. Maybe it was an error. Maybe the patient messed with it. Who knows? But if you see these things, say something so it can be taken care of. What about this? Again, this is a biopatch. We don't use this anymore, but don't put things under the dressing. If you're having trouble with bleeding, stop the bleeding first before you put the dressing on. Don't add extraneous material to your dressings. And the hub is not covered. Again, this is very similar to what we just talked about. The lines are pulling. You made it in a longitudinal fashion, so everything is pulling that dressing off. You can see that it's starting to pucker. And, oh, by the way, it goes up on the ear. So this is not a sterile dressing. Neither is this. This one is an extreme example to show you that traction and that tension. Remember to turn your catheter away and put the dressing on. That will save you from having a dressing going up into the beard and here up into the hair. Also, it will remove that traction. And by the way, you won't put the dressing over top of that tracheostomy or endotracheal strap. And then if you're going to do femoral, remember a low femoral prevents contamination, also easier to take care of for the nurses when it comes to that insertion site. Okay. Here's our website, MCG Ultrasound Education, and if you go there, you can find all of this information in small segments. Please review this material before you come and you do any central lines with us. Thank you very much.